Hello, my name is Adisa Stewart, and I am a somatic practitioner, educator, researcher, working at the intersections of somatic psychology, trauma-informed practice, mental health, and community care. In this video, I'll be providing a summary of my presentation from crisis response to life promotion, suicide awareness and prevention through a somatic, relational, harm reduction, and community care lens. This conversation really acts as to hold two truths at once. One, we must take the possibility of someone ending their life seriously while refusing to reduce the person to their crisis, diagnosis, stigma, or their worst moment. We also have to respond to immediate danger while also asking what makes life feel impossible and what relationships, resources, treatment, cultural conditions, and community supports might make life feel possible again. That is the central thread of this presentation. So we're going to be talking about suicide, substance use, harm reduction, and the therapeutic relationship, and what happens when someone is in so much pain that continuing to live no longer feels possible. But this isn't about reducing people to their worst moments or seeing them through only the lens of risk. Instead, I want us to explore a more difficult question. What does it mean to stay connected to the whole person when someone is experiencing a suicidal crisis? And what would it mean to move beyond simply preventing death toward creating the conditions in which life becomes more possible and worth living? So, a conversation about suffering. When we talk about suicide, we're talking about suffering. And that suffering is not abstract. For some people, this may connect to personal experiences. For others, it may connect to someone they love, support, or have lost. So I invite us to make room for complexity. We can take suicide seriously without reducing someone to suicide. We can take a risk seriously without reducing someone to risk. And we can talk about suffering without assuming that we already know exactly what another person needs, right? So before asking someone else to stay with us, not to end their life, to stay alive, to stay connected, to stay in conversation, I think we also have to ask ourselves what it means to stay present with suffering, all right? So the somatic practice in this presentation invites us to just take a moment to notice your breath, notice your body, notice the space around you, notice your capacity. You might feel your feet on the floor and just look around you, finding one or two objects that can really anchor you and ground you in this moment. Finding your support so you can return here whenever you need to. And this is just a reminder that when conversations become difficult or activating or triggering, we can begin by grounding ourselves, right? So we don't have to make difficult feelings disappear. We can simply notice. So I want you to notice that and say out to yourself, I am here, I am in this moment, and I can take this one moment at a time, right? What makes life feel more possible? Excuse me. So when someone is suicidal, we absolutely have to respond to immediate danger. We assess risk, we increase safety, we stabilize, we connect people to appropriate care and support. But I believe we also have to ask a second question. What makes life feel possible? So there's a difference between helping someone survive a crisis and helping someone experience life as something they actually want to remain present for. Crisis response asks, how do we get through this moment? While life promotion asks, what would make your life more livable? That includes connection, belonging, agency, meaning, and possibilities. We need all of them. So we have to keep someone safe now while also thinking about the conditions that might make life worth living for. So there's also no singular pathway into suicidality. A suicide crisis may emerge from things like depression, trauma, substance use, grief, chronic pain, relationship loss, marginalization, isolation, or a combination of many experiences. This is why we have to resist overly simplifying explanations. The psychological is connected to the relational, which is also connected to the social, which is connected to the structural, which is connected to the body. So what is the story of this particular person? What have they been carrying? What have they lost? What have they been trying to survive? And what has made it difficult for them to imagine another way forward? I believe that there are two questions that we don't ask enough, questions that I think can help us to really shift the focus um, towards a more societal frame. So asking questions like, what happens inside us when someone tells us that they are holding suicide ideation? Also, how does suicide shape the way our society understands mental health? When someone we love and care about may tell us that they have some suicidal thoughts or ideation, it's completely normal for us to feel fear, anxiety, a sense of urgency, responsibility, or an overwhelming desire to rescue them. We may become terrified of making a mistake, or we may feel that we are responsible for preventing every possible outcome. But that raises an important question. And that question is, can I stay present with someone without immediately trying to fix them? Furthermore, how does suicide shape our society's understanding of mental health, right? So we can begin to see the suicidal person as a problem to be fixed rather than a whole person experiencing profound suffering. So we have to examine both how we respond to suffering and the beliefs we carry about that type of suffering, right? So mental illness, death, and the role of the person that is providing support and care. I don't want to die. I don't want to live like this. This statement captures something important about what is called or referred to as ambivalence. Someone can want the pain to end and still have a part of themselves that want to live. They can feel hopelessness and yet still long for connection. They can believe that nothing will change and still wish that something could. So this is where the framework of the authentic self and the anti-self becomes useful. The anti-self can represent the internalized voices of self-attack, such as, you're a burden, you're worthless, nothing will ever change. And they may also be part of the authentic self that still longs for connection, meaning, agency, or more life. So our role is not really to argue with the person or tell them that they shouldn't feel this way. It is for us to listen for the part that is still there and create opportunities for connection with it. And I want to be clear here, ambivalence is not the same thing as safety. We still assess risk and respond appropriately, but ambivalence can give us a place to begin. So when survival strategies become risk factors, this tension becomes even more complicated when we consider substance abuse, for example. A person may use substances because they're trying to cope with trauma, insomnia, intrusive thoughts, emotional pain, or overwhelming experiences. Substance use can increase vulnerability and suicide risk, but it may also be functioning as a survival strategy. So this is where harm reduction comes in. Harm reduction asks us to begin with the reality of where are you, what is happening, what harm can we reduce, what support is possible right now, and what options can we expand on. So meeting someone where they are does not mean leaving them there. It means starting from a place that actually exists, right? The helper's dilemma. So when someone says, I don't know if I want to die, I just don't know how to keep living like this. It can be difficult not to move in immediately to rescue them. We may want to save that person, relieve their pain, or guarantee that They're going to be okay. But we have to also ask, can I stay present without taking over? Can I deeply care without believing that I can control the final outcome? We alone are responsible for our responses. We are responsible. We are responsible for appropriate assessment, consultation, intervention, and and providing connection to support. But we cannot control another person's internal world, and recognizing that limit doesn't mean that we care less. It means that we are learning how to practice supported presence rather than swooping in to rescue someone. Validation is not an endorsement. One of the most important distinctions in this work is between validating someone's experience and validating their conclusion. I can say your pain is real without saying your hopelessness is the truth. I can say, I understand why this feels unbearable without saying there's no way out. All right. So this is not forced positivity. It is holding two different truths at the same time. I believe you about how much this hurts, and I don't believe that in this moment I don't believe that this moment has to define you for the rest of your life. So this is an example of how we're validating the experience while protecting the possibility that something else may eventually become visible later on. That isn't going to be a quick fix, all right? And here's a reminder that the person is not the crisis. So in severe distress, a temporary state can become an identity. You know, thoughts of I am hopeless, I am a burden, I am broken, I am suicidal. So part of the work is creating more of a separation between the person and the crisis. You're not denying the crisis or not minimizing the risks, but you're refusing to really let the crisis become part of that person's entire identity. This crisis may be real and the pain may be profound, the risk may be serious, and the person is still so much more than all of that. And then there are some cornerstones of intervention that I also wanted to share. So I bring this together through these points of intervention, right? So first, a validating relationship, which is where you create a space where the person can tell the truth, nothing but the truth, without immediately feeling judged, abandoned, or panicked over. Secondly, making room for difficult affect. So allowing space for grief, anger, fear, shame, hopelessness, for example, without immediately trying to eliminate them, those feelings. Third, there's integration. So helping the person re reconnect with a sense that life is larger than the crisis itself. And fourth, there's connection. So helping someone know that they do not have to carry unbearable pain entirely alone. So none of this is a quick fix, but it offers a way to stay with someone beyond the immediate crisis, right? So thinking, what happens after, this crisis moment? So even the best therapeutic relationship cannot solve a problem that is partly created by systems that are also inaccessible when people need them the most. So what happens when someone finally says, I need help, but there's a 6 week wait, a 6 week wait, sorry. They can't afford the treatment, they don't have transportation, and the services are not culturally responsive. So treatment access is, we know that treatment access is a huge part of suicide prevention, right? If we tell people to reach out or get support, we also have to be building systems that are capable of responding when they finally do reach out for support and treatment and care, right? So we cannot keep asking people to meet us where they're building systems that only work when they arrive exactly at, exactly only when they are the right resources available. So going beyond prevention. So sorry, beyond preventing death, and what are we building towards? So if we're really serious about suicide prevention, we also have to ask, what are we helping people live toward? Being alive and experiencing life as livable are not necessarily the same thing. So prevention has to include life promotion. has to include connection, belonging, agency, meaning, hope, possibility. We also cannot promise that life will never hurt, but we can work toward creating lives in which pain is not faced without support. The conditions that make life more possible. People don't experience psychological distress outside of the conditions of their lives. Things like housing, insecurity, discrimination, poverty, violence, marginalization, and inaccessible care all shape how people experience possibility. So we have to be careful about individualizing everything. Sometimes what we call an individual mental health crisis is also a response to unbearable conditions that people are living and working inside of. This doesn't mean that we can't support the individual. We absolutely do. But we also have to ask, what needs to change around this person in our culture, in our society, in our communities, in our systems? We cannot therapize our way out of every structural problem. We cannot mindfulness our way out of poverty, for example. So if we want people to experience life as more enriching, more fulfilling, full of possibilities, we also have to create conditions in which the possibilities can actually exist. While also reminding ourselves that we cannot hold this all alone. We also have to talk about the people who are doing the holding. So this work can create things like fear and grief and hopelessness and guilt that we, as holders, supporting other people, caring for others, can internalize. And one thing I know for sure is that helpers need helpers too. We need consultation, we need peer support, we need systems of care, we need community. No one person should have to carry the weight alone of suicide prevention, right? Moving from individual crisis to collective care. As I said previously, suicide prevention cannot be in the hands of any one person alone. It cannot belong only to a family, and it cannot belong only to the person in crisis. It has to be a collective effort. And sometimes collective care is simply checking in, listening, helping someone make a call, helping someone find transportation, staying connected after the immediate crisis has passed. And sometimes collective care means changing systems, improving access, reducing stigma, creating culturally responsible services, and building communities where people experience belonging. So the question becomes, how do we build a world in which people don't have to wait until they are the edge of unaliving themselves before support becomes available? So, with all of this said, I want to return to the question, what will I do differently? What will I ask? What would I listen more closely to? Will I take someone's pain seriously without reducing them to their pain? Will I validate their experience without validating their hopelessness on alone? Will I help reduce shame? Will I connect people to care? And will I stay connected after the crisis? And then there's the larger questions of what needs to change around this person, right? Because maybe suicide prevention is not only about preventing death. Maybe it's also about creating more opportunities for life. So we cannot promise someone that life will never hurt, but we can work toward a world where no one has to face unbearable pain without connection and support or having options. And perhaps when someone says, I don't want to die, I just don't want to live like this. You don't have to rush to convince them that everything is going to be fine. And we can begin by saying, I hear you. Let's start there. Let's really understand what's within. Let's figure out where the support is needed. Let's see what we can change. And let's not assume that this moment is the whole story of that person's life. So I also wanted to leave you with a reminder that if this conversation brings up anything for you, you don't have to hold it alone. And if you're concerned about someone else, remember that you can care deeply without carrying the entire responsibility yourself. You can ask, you can listen, you can stay connected, you can show up, and you can also help someone get connected to the support that they need. All right. So here are also some numbers that you can call. if you or someone are experiencing a crisis.